Okay, why don't we go ahead and get started? Welcome, everybody. Apologies for the repetition. My name is Joe Gogler. I'm a professor here in the School of Public Health at the University of Minnesota. I direct our Center for Healthy Aging and Innovation. I also direct what's called the BOLD Public Health Center of Excellence on Dementia Caregiving. I'm also involved with our Minnesota North Star Geriatric Workforce Enhancement Program, which is bringing to you today a really exciting and timely panel discussion and conversation where we hopefully will be answering your questions about de-prescribing with dementia. And when thinking about this particular Q&A panel, I couldn't have picked two better individuals to be addressing your questions. First, we have Dr. DeLon Canterbury. He holds a PharmD, and he's a de-prescribing implementation strategist, as well as president and CEO of Geriatrics, Inc. He's a founder of the De-prescribing Accelerator online coaching program for senior-facing pharmacists, nurses, and prescribers and social workers to implement and integrate de-prescribing into clinical practice. Again, couldn't think of a more ideal person to be leading our panel discussion today. As well, we have one of our famous and favorite geriatric pharmacists, Dr. Amy Busker, PharmD. Both Dr. Busker and Dr. Canterbury are board-certified geriatric pharmacists. Dr. Busker is with Fairview Partners in Geriatric Services, where she provides medication therapy management to patients in the community, as well as in assisted living settings as well. So with that, I'm going to turn it over to Dr. Canterbury. They have some slides about Dr. Canterbury and Dr. Busker addressing some of the questions you submitted prior to our webinar today. They'll begin with answering those key questions. Then we're going to open it up to full Q&A for the second half of the conversation. So please submit your questions and answers, or your questions specifically in the Q&A panel. I'll be reviewing them, moderating them, collating them, and then in the second half of the presentation, I'll be directing them to Dr. Canterbury and Dr. Busker. Dr. Canterbury, please.
Thank you so much for the lovely intro, Joe. Always a pleasure to be back, and I hope you all are doing amazing today. Honored to be here again. I'm Dr. DeLon Canterbury with Dr. Amy Busker, and we'll be talking about de-prescribing. So we'll go on and get started. So really today, we're going to cover a bit about what exactly dementia means. We'll talk about more about what de-prescribing means, and we'll talk about the impact de-prescribing has in our communities with our providers and for our caregivers that are managing this. We'll also talk about potentially inappropriate medications that come across our line of work and basically perk up our ears on when to start talking about de-prescribing. And then we'll discuss some potential real-world examples of de-prescribing within our tenure of the program. So first up, gotta always ask, what is de-prescribing, right? I'm sorry, what is dementia? What does that mean? What does it look like? And for those who are here, you probably have some form of familiarity of this, but really dementia affects changes in our brain. It affects the way we're able to critically think, how we develop language, how we communicate. And so dementia really is an umbrella term for changes in thought process that can affect your daily living. So with this being said, we are seeing a number of reasons why dementia may come about. We've heard of Alzheimer's disease, which is the most prevalent form of dementia, but there are quite a number of different forms of dementia that can exist. The second leading cause is vascular dementia. So for instance, some patients who may have had a stroke or other uncontrolled high blood pressure or diabetes, they can have vascular dementia that affects healthy brain cells from communicating with each other. So keep in mind, this is an umbrella term, basically meaning there are different forms and different types of mixed dementias, but dementia is just a word we use to categorize changes in that type of thinking that affects a patient's daily living and critical thinking skills. So there are a number of symptoms that may come about for those who may be suffering from dementia. And there are also a number of different ways people are staged when it comes to dementia, from mild dementia symptoms or mild cognitive impairment up to severe, where people are needing around-the-clock 24/7 care. And so it may manifest as, of course, having some issues with memory. And one thing I want to beat into us today is learning that having memory loss or changes in memory is not a normal part of aging. Okay, that is a misconception. So, any significant changes you may see with a loved one or even a patient when it comes to memory should be addressed promptly. Now, when it comes to the signs of dementia, you may have loved ones who have difficulty with everyday tasks or managing their finances or their bills, remembering their appointments, even maybe not knowing where they are or getting lost easily can be a pretty hallmark sign, as well as, and I see this a good bit, changes in mood and behavior can also occur. So really, we're looking at things that are affecting their daily living, like things around the house could be as simple as uh, using the bathroom can become a burden for some of those people in maneuvering. So dementia can definitely manifest in different ways, and I want to make sure you all leave aware of what some of these signs and symptoms may look like. So unfortunately, dementia is on the rise, not just in the US, but honestly across the entire world. It's sadly anticipated that by 2050, out of our 6 million people that have dementia now, it is expected to more than double to up to 14 million people across the entire world. Now, here in the US, we do have more prevalence in some of our more Bible Belt southern states. So the Southeast does seem to have a higher prevalence. And what they see in the literature is that there are unfortunately worse outcomes for people that live in rural settings as compared to those living in urban settings. So we're seeing almost a tripling of people um, who have dementia across the world. Now, we are also seeing patients living longer with dementia. And so this is going to require more public services, more senior care need or organizations, and of course, care providers to help caregivers along this journey. One risk factor that comes to mind are just simply not being active. There are new studies that show that exercise, movement, and nutrition can all reduce the risks of having cognitive impairment or dementia down the road. So having a sedentary or laid back lifestyle that isn't as active can actually increase your risk of having dementia later on in life. So yeah, we're seeing increased mortality and morbidity in those rural settings. And we are going to be seeing an expected doubling, if not tripling, of the cases of dementia by 2050. So a lot to take in. But yeah, notice, the Southern Belt tends to have a higher prevalence, and some of our Western and Midwestern states have a little bit less. There's a new case for dementia every 3 seconds, okay, in the entire world. There are about 10 million new cases of dementia worldwide. So, of course, America has its good bit, but I cannot neglect the fact that people that may identify with Latino or Black or African American have a higher risk of having dementia. So, we're seeing increases across the world with this, not to mention the expenses that are associated with this among the family and caregivers and even the health system in managing people with dementia. If we were to total all of that worldwide, it would lead and equate to the 18th largest economy in the entire world. So very significant costs that are implicated with our public health measures, but more so as a clinician, as we're going to be seeing an increased aging population living longer and having more needs and advanced care later in life. Oops. So that being said, unfortunately, we expect about a third of seniors will actually die from having some form of dementia here in the US. So we've even seen so many caregivers that go unnoticed in having to manage these costs. And they're looking at about 15 million people that are expected to provide about 18 billion hours in just caregiving for people alone. That is really significant. And generally, it's unpaid. And the worst part is, and this is the insidious part of being a caregiver sometimes, is as a caregiver, you tend to neglect yourself and you end up being susceptible to some of those conditions later on in your life. You no longer do your own visit. You're worried about grandma getting better. And so that selflessness, unfortunately, can lead to other implications. Could be as insidious as substance abuse because you're just not doing well emotionally with handling a loved one. But even so, our own health system with CMS alone is incurring over, at least by 2050, is expected to incur about $1 trillion in just managing these expenses alone. And so with all these symptoms being, oops, sorry, click the wrong button. Let me go back. All right, there we go. Great. So all these symptoms we also had already mentioned, there are a number of reasons why this may happen, but a lot of them can be managed when it comes to chronic conditions such as diabetes, high blood pressure, having stroke, having a healthy lifestyle can be factors to mitigate some of these risks that are seen with having dementia later in life. So with Alzheimer's being the 6th leading cause of death in the US, it's important to note that this is more than people that are suffering from breast cancer and prostate cancer combined. And there are some differences, again, like I mentioned earlier, between having Alzheimer's and just having dementia. There are different types of dementia, and Alzheimer's tends to be the most predominant form that we see in clinic. We see that also 8 million people have dementia in the US, with about 6 million having Alzheimer's disease. And some people may present with mixed dementia. They may have a mixture of vascular and Alzheimer's, or frontotemporal, or Creutzfeldt-Jacobs disease, or different types and forms of dementia, which we'll discuss later on. One thing to note is that dementia is hard to manage all around, whether we're talking about socially, emotionally, physically, but even medically. We don't have the best drugs on earth to really reverse dementia. We're kind of just treating what we can as it comes along in terms of symptoms. Nothing can really, or has been shown. We do have some new evidence with some newer biologics that came out in the past few months and slated to come out in February. We have some biologics that are looking to target specifically some of those beta amyloid plaques, which is the hallmark presenting biomarker for Alzheimer's disease. So we do have some meds that are on the market, but before we had Aduhelm come to market, we really didn't have much. We were essentially treating symptoms and trying to use therapies that haven't really been updated for about 20 years until these newer biologic agents have come. So that being said, it can put some of our providers and of course our caregivers in a bit of a tough space in trying to manage symptoms or behavioral management related to having dementia. The efficacy and safety is fairly limited, even though we do have some that are been the mainstay of care for quite a bit. The variability of response is just through the roof. You don't always know who's going to get the best benefit. Providers are sometimes forced to use medications off-label, and I can't blame them. They don't have many options, but we'll try to talk through ways that we can maneuver some of those unnecessary, potentially risk-averse approaches. And there's also a fine balance of figuring out what the caregiver needs and what the patients may need, because they both have to worry about quality of life in managing someone's care. So there are indeed barriers, but it doesn't mean that it's the end of the world. And we're going to talk through some of those options today.
And before you go on there too, DeLon, I know one of the questions that we received from registrants was as far as the medications that are prescribed, early on for earlier stages of dementia versus later. And I think this is kind of ties into with the, barriers that prescribers face for use of these, is because, as DeLon mentioned, in general, the medications we have really, I think it's a misconception sometimes that they can slow progression, and it's not slowing progression. It maybe can, they can help to delay or prevent symptoms from becoming worse for a limited amount of time, but there's pretty small benefit with them. So I just wanted to emphasize DeLon's point that, they don't stop or slow dementia. And then just kind of pointing out too that yes, there are, to answer that question, there are the medications that we focus on for mild to moderate stages versus moderate to severe. So for example, our acetylcholinesterase inhibitors, so that's your Aricept, Exelon, that class, except for the Exelon patch and the high dose of Aricept is generally mild. It's mild to moderate dementia that we use that for. And then Namenda is moderate to severe, where we see that. So I just wanted to make sure we answered that question as far as a more specific question with regards to meds. And part of the reason too is because the way these medications work, the cholinesterase inhibitors, I mean, they prevent the breakdown of acetylcholine, and acetylcholine is that important brain chemical for memory and for thinking. And as the disease progresses, the brain makes less of that acetylcholine, so it's less impact of those medications that we see for mild to moderate dementia. So I just wanted to add that in.
I love it. I love it. I love it. So thank you for doing that, Amy.
Yeah.
And speaking of some of those issues, I think you had a great example of a prescribing cascade. And so I want us to make sure we dive into that. So for those who may not be familiar, prescribing cascades essentially are where you have one drug prescribed that's meant to treat the symptom of something. And unfortunately, it leads to this whole cascade of different drugs that are being added on to treat the side effect of a medication and not necessarily a new health condition. So Amy, I want you to take away that and bring home that point.
So I will say, unfortunately, this is something I see every day in practice. I'm sure you do too, DeLon. And so an example that I have that I came across not too long ago was a patient who was on bupropion. And this is a medication that's an antidepressant. And unfortunately, it can have this side effect of anxiety and agitation. And so this patient had anxiety and was prescribed lorazepam. And lorazepam is used for that anxiety, unfortunately contributed to memory loss, confusion. And now this patient was also on donepezil. So, it's looking back, you could see bupropion was started, then lorazepam, then donepezil to help with the memory issues. That led to sleep issues, which led to the use of a sleep medication, which led to dizziness. And we could go on and on all day, unfortunately, but it's really important to be able to pay attention as you start a new medication or doses are increased to, if you feel any different, if it's potentially a side effect that you're experiencing, because we don't want to add on another medication to treat a side effect of the previous medication. So that is something that's really important to be aware of when you or your loved one, starts medication or increases a dose.
Yes, it's critical, honestly. And part of our job is playing this mystery solver like Nancy Drew, like what was the beginning of all this, like what started this mess? And I think that yeah, it really ties into why we, especially in the dementia space, we really have to bring home non-pharmacological approaches to help manage some of those behavioral symptoms, right? How are we looking at redirecting therapy, or even helping those talk through what they're feeling, or maybe humoring, if they're seeing someone or hearing something, asking open questions about it. Don't dismiss what they're feeling or what they're thinking. And so there are some pretty cool techniques out there on YouTube. I think Teepa Snow is pretty infamous for her amazing work and using holistic approaches in managing people with dementia and behavioral symptoms. But a lot of this, again, what can we do without jumping to a prescription first? And I think that's really the hard mark of just good prescribing habits and just being judicious in medication safety. Another word kind of thrown around in our world is polypharmacy. So technically, it is the use generally of 5 or more medications And generally, as we start increasing by 5s, 10, or 15, the risk of harm increases. And this is for anybody, regardless of what health conditions you may have. Some contributing factors may be seeing multiple doctors, maybe checking out different pharmacies, and they may not have all the same medical record that has an idea of what they're taking. Or a risk factor could be simply having multiple chronic health conditions. And with a population that's aging, we have a population that tends to want to self-treat and self-medicate. And so some patients are very quick to say, you know what, I'm not going to tell the doctor about this. I'm just going to use this over-the-counter to help me with energy or to help me with fatigue, whatever. And that may not always be disclosed in clinic. And that can lead to potential drug interactions or drug harm. So the number that I try to get people down to is usually around 5, whatever within reason. It's not a hard number. It doesn't mean if you're on 8, you're in trouble. It just means that there is a higher risk of potential harm. And it's important for you to consistently ask, all right, it's my annual checkup. What can we do to safely get off of some of these prescriptions? And I mean this regardless if it's dementia or not. What are some things we don't need anymore? And just have an open dialogue with your pharmacist or care provider on what's really truly necessary. Amy, you want to add anything to that?
Yeah, just remembering that this includes, any, not just prescription medications, but over-the-counter herbal supplements, anything, nasal inhalers, whatever the mode of, that you're taking it, it's important to remember all of those and have an updated list, updated medication list. So important.
Yes. So important. Bring that bad boy everywhere. Keep it updated. List everything you can and bring it to all of your clinicians, either to your PCP or a specialist, even a therapist. Whoever you're seeing, they all need to have an idea of what you're taking. So excellent point. So we kind of already mentioned that there are several different types of dementias. We have Alzheimer's, Lewy bodies disease, mixed dementia, and all of them generally have some different hallmark features about them, but how we manage them may have some actual similarities. What are also some other risk factors that come to mind regarding dementia? I mentioned chronic diseases are a big one, but smoking is a huge risk factor, and it's never too late to consider stopping smoking. About a 41% increase in those who were smokers, and about a 40% increase in those who simply have high blood pressure. I will say diabetes contributed to almost a 77% increase of having dementia later in life. So again, these are chronic conditions, or so to speak, symptoms that can be managed now and can lead to big wins later in life. But generally, your genes especially matter. We're seeing a huge a bit of attention being given to, I believe, Chris Hemsworth, who announced that he has genetically the APOE gene, which has a really, really high risk factor of him having Alzheimer's later in life. And I think he's actually taken a sabbatical just to spend time with family. So genes absolutely matter, and they actually matter as well for certain therapies. But your genetics can predispose you to potentially having Alzheimer's down the road. And there are, of course, such a thing as having young adult onset Alzheimer's as well. Of course, age is a risk factor. Having any history of delirium, having a head injury or concussion can be a big one as well. Having uncontrolled cholesterol and, of course, having alcohol abuse can all contribute to this. Another thing I want to also mention is sleep hygiene is also a known risk factor. If you're not getting between 7 to 9 hours of sleep, less than that can actually put you at risk of having dementia later on. And so managing that hygiene now is critical as well to mitigate harm.
I want to mention too, I know there was some questions about recommendations for people that do have comorbidities, so such as high blood pressure, high, cholesterol, as well as depression and anxiety and things like that. And as DeLon mentioned, we can do things to help help with the high cholesterol and help control blood pressure as well. Things that we can do to help reduce cardiovascular risk, as well as reducing the risk of a stroke, and to help reduce the risk of cognitive decline. So it is important to identify and treat those things. I do want to say though that we don't want to do it too aggressively as well. Sometimes, especially and we'll talk a little bit about this, but as people get as the dementia progresses too, and goals of care change and things like that, it's not always appropriate to be treating these per the guidelines necessarily. It's not necessarily appropriate, because we need to consider goals of therapy. We need to consider frailty. We need to consider life expectancy, cognitive and physical function. I think too, just always worth mentioning, older adults, with multi-morbidities, with a bunch of disease states, are often, very underrepresented in studies too. So I just wanted to mention that.
No, I love that. I mean, that's kind of the fine art of being a clinician and using our judgment. We can't always just do what the guidelines say, even though it'd be nice. But having that clinical picture, knowing what the caregiver wants, what the patient wants, what the family wants, they have to be in unison, and there has to be a shared decision-making around that to really get to the best needs for our patients. So it definitely isn't a fine art to just figure out, all right, you'll be on this when you're at this stage. It has to be given with patient buy-in. So,
and it helps to guide our de-prescribing. So
yes. So we've already discussed signs and symptoms of dementia. So I'll skip this slide. But I do want to give light to, unfortunately, the rising use of inappropriate medications, specifically the use of antipsychotic medications for those who may be suffering from dementia. There was a New York Times article that released this study they did, looking at over about 750 nursing homes in the past decade or so. And what they were looking for was the use of certain types of medications within dementia populations. And what they're finding is that there has been a 21% increase on antipsychotic use. So these are drugs that are traditionally used for bipolar disorder, schizophrenia, and sometimes major depressive disorder. But they are often, unfortunately, oftentimes used, usually off-label and inappropriately, to manage people who may be suffering with behavioral symptoms related to dementia. So what this article unveiled was that not only this has been increasing over the past few decades, and this is literally since the FDA has put a black box warning saying, hey, do not use antipsychotics from people that have dementia and behavioral problems associated with that. But even so, we're seeing this in the very same nursing homes that a lot of us may have someone that we're paying for to be in. So it's important to know that these medications, although traditionally used for other reasons, we're seeing a spike of them being used inappropriately for those who are dealing with dementia. And some of these meds we'll dive further into, but this came out just last year. So even with the FDA saying, yes, don't do this, even with, unfortunately, COVID and an increase in staff shortages and spikes in care, we're still seeing this being done. And it's something I have to face probably as much as Amy does in our line of work. So it's something we have to still use as an opportunity to re-educate not just caregivers and patients, but our providers on better, safe practices for prescribing. So really, someone had actually asked a great question about what exactly is the meaning of de-prescribing? How does that look? I'm going to let Amy go ahead and dive into that and take care of what that means.
So yes, de-prescribing, we're essentially, we are removing medications that may no longer be necessary. And so the goal of this is to manage polypharmacy, to improve outcomes. We want good patient care and a rational use of medications. So that is our goal, is we want to make sure people are on only what they really need to be on. And so as far as, when to consider deprescribing, if something isn't indicated, sometimes you get started on something years ago and maybe it made sense at the time, but it's no longer, it's continued on and there's really not a good reason for it anymore. See that one a lot. So, it might be that it's just not indicated. Maybe it's not working. If it's not working for you, we want to get rid of it too. Changes in, care goals or patient preference, that can be a time to, consider deprescribing as well. When risk is greater than benefit is, of course, a big one. So if somebody is having an adverse drug reaction, if they're having a side effect of a medication, that is a time to look at potentially reducing or getting rid of or changing to an alternative agent if needed. High risk medications, I know DeLon every day too, we're looking for those high risk meds, which we're going to talk more about. But that is if somebody is on a high risk medication, we want to consider getting rid of that. With advanced or end stage illness, or terminal illness, of course, we want to look at deprescribing. For people who have dementia, or are fully dependent on others for care, if and specifically with regards to dementia medications themselves, is if you're noting a decline in cognition or function, and I think we're going to talk a little bit about that more, so I won't get too much into that right now, but that's a time to think about deprescribing as well. If somebody's frail, with frailty, you're more at risk for side effects. So that's important to keep in mind. If you're taking a medication, a preventative medication, that's unlikely to confer any benefit for the, additional or for the remaining life expectancy. That's time to think about it too, is as far as maybe your goals are more now symptom control versus prevention. It's a good time to think about deprescribing as well. There are, of course, risks and benefits of it. And so I think the benefits, we talked about polypharmacy and what that can lead to. So, of course, the benefits we can see with deprescribing are the fewer adverse drug reactions. We see, fewer drug-drug interactions, drug-disease interactions, a reduction in falls. That's a big one. They can be very debilitating. And so whatever we can do to avoid falls, it improves adherence, especially in dementia, if still living at home, and for anybody with cognitive impairment, and even if not, it can be difficult managing a whole slew of medications. So obviously deprescribing can help to improve adherence too. We see a reduction in hospitalizations, not to mention costs, mortality benefit. And then, as I mentioned before, I think polypharmacy really can result in a decline in cognitive and physical function. And so, with deprescribing, we have the benefit of, again, improved outcomes and quality of life. I can't tell you how many times, it's very rewarding to be able to get somebody off of all these medications and see them do better, and mental fog lifting, and being able to function better, feel better. So lots of benefits to it, certainly. We do need to balance that with potential risks. And so, of course, with reducing or eliminating a particular medication, you run the risk of that medical condition or symptom returning. The one thing I'll say, when people are afraid of that, we just talk about what to expect, what to watch for, because we can always restart it if we need to. Or if there's a safer alternative, then that's a good time to think about that. You know, another risk is adverse drug withdrawal events. So medications, for example, antidepressants, you know, if somebody's on an antidepressant and they've been on it, you know, for a certain period of time, it is important to taper off of some of these medications. And if you go too fast, sometimes you can risk some potential side effects from that. And then the other thing to think about, you know, is the reversal of drug-drug interactions. You know, so for example, if somebody's on warfarin, you know, and they're taking a medication that can interact with that, and we're removing that medication, that's going to impact the warfarin management. So that's something we always need to be aware of as well. But I think, can you think of anything else that I didn't touch on, DeLon?
Man, you pretty much nailed it. Really, I'm only thinking about caregiver burden, and if that med list is shed from 25 to 9 or 5, the caregiver's life is easier trying to get them to take these prescriptions, and also honestly the provider benefit of knowing that we're not treating another preventable medication error or other unexpected side effect can save them time and capacity, where we're in a space where, you know, it's tough even seeing a doc with all these flu, rhino, and COVID out. So I think it helps the health system overall. It helps with not just the cost associated with those going into the hospital and hospitalizations, falls, et cetera. But again, we're talking about the quality of life for our patients and our caregivers. I think it's a win-win for everybody. But like you mentioned, I think you did a great job. Like, there are withdrawal effects with certain types of meds. And like anyone here, we're not going to tell you to just stop something cold turkey. You have to discuss with a provider, and you have to get the permission to consider getting yourself tapered off some of these meds. And kind of with that, yeah, go ahead.
Sorry, I was just going to say, with some of the medications too, you know, I mean, so for example, an antipsychotic, let's say we stop an antipsychotic or taper it off, we want to even be paying attention for, you know, a few months after. We're still watching for target symptoms, you know, and things like that. The other thing I just thought to mention as far as when to consider deprescribing, that I don't think I brought up yet, was, you know, sometimes too with dementia, and as it progresses, patients will be not wanting to take their medications. So they're refusal of medications, which can be very upsetting sometimes to caregivers, you know. And so I think that's a good time to really look at that med list and think about, what do we really need to continue with versus not. So I just thought to add that.
Yeah, spot on, honestly. I mean, why wait until someone ends up in hospice for us to start talking about deprescribing? And for those in the world, a lot of times that's when that conversation happens, unless you're working with a geriatrician or amazing people like Amy who do this on a day-to-day basis. But I think it's a mindset shift too, guys. It's not all on clinicians to start this process. I think there's a ton of power in patients, in caregiver advocates, patient advocates who at least have some knowledge about their loved ones' changes in body or symptoms, side effects, to talk about, you know what, I am a bit worried about some of these meds. What can we do to work on this? A lot of my wins come from caregivers and patients who just love their grandma and want them off of the pills. So I think it takes a team-based effort. It shouldn't be seen as like an attack, like, oh, you're putting my mom in harm's way. Just have an open dialogue, have a conversation about deprescribing, about, is this truly doing what it's supposed to do now? And then make it a continuous process. It's not a one-stop shop. It's an ongoing process that you need to emphasize and advocate for.
Yes.
Love it. Love it. So really with that, we're going to just segue a bit to some of the potentially inappropriate meds that we likely see a good bit in our line of work, but also what prompted me to absolutely start talking about deprescribing. And so we will kick it off and go on in. So, you know, one reason why I'm extremely passionate about this comes from having a grandmother who suffered from dementia. And a lot of her symptoms honestly could have been avoided had she not been on a particular antipsychotic. She was in a skilled nursing facility in New York, where my family was from. And during that time, her mild cognitive impairment almost went down to severe. It was pretty bad. It got so bad, she got kicked out of the nursing home that she was in, and my parents, full-time employees, had to move her down to Atlanta and try to figure out how to take care of her themselves. So I wasn't quite a pharmacist yet to fully advocate to that level, but I did see how much hell my parents had to go through as caregivers and full-time employees, and still trying to send kids to college and still live their lives. So it's not easy. But what was the causative factor in my case was my grandmother being on ziprasidone, which is a second generation antipsychotic we have listed here. And so a lot of these antipsychotics, as I mentioned, were usually typically used for people with bipolar disorder or schizophrenia. And so they're, yeah, but mainly those two. But that being said, we do see these used, and particularly you'll likely see Seroquel used the most within this setting to help manage behavioral symptoms around dementia. But I want to make sure I list these because, one, it not only affected my grandmother, it could easily happen to anyone listening, but I want us to all be educated and empowered and know what some of these drugs are doing. You got to know your med list and know what's on them. So even though the second generation antipsychotics are touted to work a little more safely, the evidence still isn't really robust to say this is exactly worth the benefit. And we're going to explain why in a little bit. But what I have listed here, generally, you're not going to see as much Haldol and Trilofan in the acute setting. You more likely see the second generation antipsychotics, which may be Abilify, ziprasidone, that's the one my grandmother was on, risperidol, Seroquel, and Zyprexa. You'll likely see more of those. And the reason why I have risperidol bolded is because this is the one that actually has the highest cardiovascular mortality out of all of these that are listed here. Okay.
I think too, it's worth mentioning that unfortunately, one of the side effects is these medications can increase the rate of cognitive decline, and can, actually contribute to confusion too. So it's, again, just being very aware, because sometimes there's appropriate times. Unfortunately, we see these used a lot of times inappropriately. But if somebody is having upsetting hallucinations or delusions, then it can be appropriate to use them for a short period of time, as long as they're working too, and we're monitoring closely. Or if they're at risk of harming themselves or others, they can be appropriate. Again, behaviors can wax and wane though, and so it is really important to try, getting people off of these as well. So, and an increased fall risk, unfortunately, with these as well. And I know, Seroquel, as DeLon mentioned, that's the one I see probably most frequently too. Because unfortunately, I think people use it for sleep, which is definitely inappropriate. So, but that one we do tend to favor, though, if somebody has Lewy body dementia, for example, for some of the reasons, DeLon mentioned earlier on with, depending on the type of dementia and, if with Lewy body dementia, we worry about, the increased risk of movement disorders and stuff. So we prefer that Seroquel in that instance. So I like to point out, I had a patient who thought she was seeing Anderson Cooper, and this was not upsetting to her. So let's not start Seroquel for that. It's one thing if things are upsetting or, but right. Sometimes I think it's important to point out that de-prescribing actually starts at that point when you're thinking about prescribing. That's where it starts, is stop and think, do we really need this?
Oh man, I love how you worded that. I really do. And not everything, not every ill needs a pill. Like you said, we
That's
start
right.
with what's really best now. So thank you for that anecdote. Perfect. And to your point about not always, or at least the caveats around when we can use some of these medications, it's important to note that if the patient is suffering from dementia and is posing a harm to themselves or to others around them, then there is reasonable use of having some of these antipsychotics on board. But mind you, the key word is at least temporarily or as a transition to maybe another form of therapy or just to taper or just help them acutely in the moment. And so, why I kind of get on my soapbox about the use of antipsychotics is to this point here, which the FDA has made clear, as well as the American Geriatric Society, that the use of antipsychotics tend to be associated with an increased mortality for patients that are elderly and are looking to use this for behavioral management. So those who may be, of course, having psychosis related to dementia, it's inappropriate generally to use these class of drugs, which we had listed in the slide previously. So this has been going out since the early 2000s, really, when the FDA started cracking down a bit more on the use of antipsychotics in some of these nursing homes and facilities. And I think there was even a comment where someone had mentioned about in 2012 how they used how they would mention the impetus to reduce antipsychotic use, but was, I guess, sad to see that it's still going on. And it is a dangerous practice, which they had mentioned. And that, of course, that danger affected me, my family firsthand. And it led to my grandmother not just hiding things around the house, but literally leaving the house at 3 a.m. and ringing the doorbell and waking my parents up that they thought she was locked in from. So that again leads a mental burden for the caregiver. And there, of course, is an increased risk of suicidal thinking and behavior, but that's more for children and adolescents. So we talked about antipsychotics, and another slightly insidious class is the world of anticholinergic drugs. So as Amy mentioned earlier, we basically propose that people who are suffering from dementia are not getting enough acetylcholine, which is basically a brain signal transmitter that tells and communicates with other parts of the brain for you to take action, to do things, and get your day-to-day going. But with that being said, some products that are available over the counter may have anticholinergic properties. And it's not really something I expect every clinician or let alone every patient to really know. And I would advise you to talk to your doctor about this or your pharmacist on really weaning down what may be considered as anticholinergic, because there isn't really just one class. It's a number of different types of drugs that can fall under this. And so we listed some examples here. Amy, did you want to take this away?
Yeah, I will. So tricyclic antidepressants. So those are your medications like amitriptyline. So amitriptyline is an old, antidepressant, but we see it usually now for things like neuropathy, nerve pain is when I typically see it. So much safer options. I will say I'll wait to mention that, I guess. Antimuscarinics like oxybutynin. So those are your overactive bladder medications. They're really not very effective anyways, and have a lot of just not great side effects, including confusion. And, that's all of these do, as you mentioned. So, and then the antihistamines like Benadryl. So this is a first generation antihistamine. So that hydroxyzine, those are, we see them a lot. I will say I used to work in the memory clinic, and I can't tell you how many people would come and they were taking Benadryl, usually in the form of Tylenol PM, and they were using it to help them sleep at night. And that would be the first thing that we would do is get rid of that. Because one thing to just be aware of with that, a lot of times people will say, but I just take it at night to help me sleep. So it doesn't, I'm fine. I just take it at night. I don't take it during the day, but it has a very long half-life, sticks around in your body for a long time. And so it definitely can impact you, even taking it just every once in a while. So it's important to know that, because what we thought, it's again amazing to see that brain fog lift and just cognition improve with that. Skeletal muscle relaxants like cyclobenzaprine we really want to avoid, and then the antipsychotics that DeLon already did a great job talking about. I think too, one of the medications that I'll see and always red flag goes up is Paxil or paroxetine. So this is, one of the serotonin reuptake inhibitors that we use for depression and anxiety. But unfortunately, it is highly anticholinergic. And so that is something, if somebody comes to me on it, and we'll try and taper off of, or maybe switch to an alternative agent. So I thought that might be worth mentioning too.
Yes, I love it. And I cannot harp enough how sneaky that Tylenol PM is. That was one of my bigger cases as well. We had a patient on 36 prescriptions who we were able to de-prescribe down to 8. And Tylenol PM was one of those drugs that added to her combo of, guess what, Seroquel, it added to her oxybutynin, it added to another benzodiazepine, which we'll also talk about. And all of that kind of just led to her being completely irritable. And so that Tylenol PM, she was using way more than we thought. And you'd be surprised how those over-the-counter meds, those herbals, they do play a role. They do have drug interactions. So definitely be mindful of what is on the back of that prescription bottle, and reading the back, it will help you get some clarity around that. So if you see PM, almost assume it's likely Benadryl in it. And maybe also assume, depending on if it's a liquid, it may have some alcohol in it too. So keep that in mind as well. Okay.
I feel like we should maybe point out meclizine too, so this meclizine is one that people will take sometimes for nausea or dizziness. And unfortunately, this is probably an example we see a lot with the prescribing cascade. They're dizzy because of, other medications that they might be on. And then meclizine is anticholinergic. So, something to be aware of too. And over the counter. So just, I can't stress enough as far as just general medication safety. Just because something is over the counter does not mean that it's safe. They still can interact, they have a whole host of adverse effects as well that we got to watch for.
So true. Yeah. So when we say anticholinergic, I just kind of want to give you guys a brief rundown of some of the symptoms of what that may look like. So when people are having a bit of too much of some of those anticholinergic drugs like Benadryl, you may get some symptoms that present like we're seeing here on the slide. Could be as small as dry mouth, dry eyes. Constipation is definitely a big one that we'll see in this world, to having a faster heart rate or beating heart. You may also see some drowsiness, dizziness. I definitely see a good bit of confusion, as we mentioned, and why that will worsen dementia symptoms. I've also seen irritability. That's another hallmark one I've seen as well. But also urinary retention, right? And so ironically, that may be why we may have people put on certain antimuscarinics to help with that. There are also some Parkinson drugs that may have some of these properties that we mentioned, like benztropine, for example, that is used for people who may be dealing with over salivating. And so sometimes I've seen it as an eye drop used orally to keep people from, or salivating too much. But yeah, any thoughts on this, Amy, you want to add?
Yeah, I think this is where it can be tricky too, with some of these Parkinson's drugs. The carbidopa levodopa, for example, where we'll see, you can see an increased risk of hallucinations, it is a side effect with them. And so then that can sometimes lead to, an antipsychotic being added on. So it just really important to, again, be monitoring for side effects, because sometimes it may be appropriate, if discussing with a neurologist, can you reduce that dose of Sinemet, just from a de-prescribing standpoint, right? Like, can we do something to help, to maybe reduce the dose, or, whatever the case may be. But that's something we typically would work with the neurologist on as well. Because again, then you'd be at the risk would be right, the increase in Parkinson's symptoms. So it's always a fine balance. As DeLon mentioned, it's such an art. It really does feel like such an art. So especially with Parkinson's meds.
Absolutely love it. Yes, incontinence, another one. So we definitely talked about oxybutynin earlier, and sometimes we have issues with urinary retention or frequency and urgency, or even nighttime bedwetting as people age. And so sometimes we will prescribe, or not me, but providers will give these as options to treat them. And well, they may actually contribute to worsening confusion because of some of their anticholinergic properties. So what is, again, another example of a prescribing cascade could be a worsening dementia prognosis because someone had a recent urinary issue, and there could be a number of factors that led up to that. But again, the fine art around this is what I want to emphasize is, yes, they are intended to do good, and we want what's best for our patients, but truthfully, de-prescribing doesn't come with a gold standard book of what to do at all times either. We do have some amazing clinical tools that we can use out there to assess potential risks and harms, but I've seen things as simple as getting someone to help with Kegel exercises or doing some PT to help strengthen some of that tone when it comes to some of that urinary frequency and urgency. And that has been able to help patients manage the nighttime bedwettings, or just having some sleep hygiene, or drinking less water, which I tend not to want to say I want people on as much water as possible because we're usually dehydrated as we age. But there are some things we can do without pulling the trigger on a prescription. So,
and it sometimes might be looking at the meds that the patient's on. Maybe they're on a water pill that they maybe don't need necessarily anymore. So there's certainly medications that can contribute to urinary frequency, and donepezil is one of them, which is Aricept. And so again, need to keep that in mind, because that's something to look at, as far as, is it appropriate to continue? Is it worth trying maybe a reduction, or if you think that it could be contributing? But I think as pharmacists, we're trained to blame the drug, so we always, whether it's incontinence, or if it's anxiety, or whatever the case may be, it's so important, as DeLon mentioned before, review that medication list, always talk about those goals of care at each visit, because just taking a really good look at that medication list is important, always.
Amy, DeLon, we're getting a lot of positive comments. Love your presentation and information. I just want to note we have roughly 30 minutes left here, and we got a lot of questions. So just let me know when you're ready to start fielding those.
Okay, beautiful. We are almost done. So we'll knock these out really quickly then, and go into the Q&A section. So I mentioned benzodiazepines really associated with significant falls risks as well as car crashes in the elderly. So alprazolam or Xanax, diazepam or Valium, clonazepam or Klonopin are also associated, and they're even worsened when combined with opioids. There's almost a 4-fold increase of respiratory depression, which can lead to overdoses, and it can impair cognition as well. So this is definitely something that brings up my red flags, along with opioids, and they're both associated with falls, fractures, and some cognitive impairment. Okay. Want to also add to make sure people today are not falling for those Prevagen scams or just get your memory back scams that are out there. If it's pretty much natural, just don't assume it to be effective. And I hate to be that guy, but when it comes to at least dementia, we don't have any evidence out there that's saying that these exactly are going to be beneficial. And then not even that, but the drugs over the counter simply are not regulated by the FDA. So there isn't exactly the quality control that we get with certain herbal products and natural products. And I'm not against them. I'm just speaking in line with the world of dementia. We mentioned OTCs. I do want to stress the importance of trying non-drug therapy. So music therapy, aromatherapy, behavioral therapy, art therapy can all be effective ways of helping people manage some of those behavioral symptoms. There are also guidelines. If you haven't heard of it, check out deprescribing.org. It's a valuable tool for clinicians to start having conversations on when can we consider stopping the donepezil or the Namenda, and is it really truly still appropriate, as Amy mentioned earlier.
I
I
think
do
too,
want to, okay, go ahead.
no, sorry, I was just going to say, because I know this was one of the questions is, you know, sometimes there can be that difficulty with maybe family members are not agreeing on, you know, what should be the therapy for mom or dad, you know, and so being able to refer to some of these resources can be helpful. So I just wanted to throw that out there too, because I know sometimes if there's difficult conversations happening, it's helpful to be able to find that resource.
Absolutely. And we're all about giving you guys resources today. Gave you some caregiver tips here for those who are also dealing and managing with loved ones with dementia. And we listed you some phone numbers in case you needed some help or support. And I'm all about getting people involved with support groups and getting that social isolation broken. Okay. And with that, love to know well, we'll go to the questions. Q&A.
Wonderful. This is tremendous. Getting so many positive comments here. Again, great job, Dr. Canterbury, Dr. Busker. One resource I wanted to point out to everyone here, and Ashley, if you could please save this from the chat and also provide it in our follow-up email. Dr. Brian Isitz is also joining us in the audience here today from the College of Pharmacy. I know you know him, Amy. And he provided a link to a 4-step process related to medications and de-prescribing that has been developed by the Minnesota North Star Geriatric Workforce Enhancement Program. Again, we'll be sharing that with you all as a resource too, as well as the slides and recording from today, because I know many of you have been asking for it. I think they're just tremendous. Let me start with the questions. As I mentioned, there have been a ton of them, so we will not get to them all, but I'll highlight the ones that at least jumped out to me in curating these. And first, for some of the more general questions, I thought this was a really great question that was raised. Is one of the big questions that must be asked and answered is, who are these drugs for? The benefit for the patient or the benefit of the caregivers or family? I thought that was a really provocative question. We'd love to hear DeLon or Amy address that.
Yeah, we could add in, or the benefit of, right, with the caregiver, if it's the nursing home or the staff, right? I mean, we need to make sure it's about the patient. So I think, you know, that's key. I don't, and because sometimes I do think, unfortunately, things can get added because staffing is tough, and they feel like throwing the antipsychotic, and unfortunately, which is going to cause them to more sedated, and maybe calm them down that way. But that's not the goal. So I think we need to make sure it's the patient.
It needs to be the patient straight up. But I get it. You're balancing quite a lot. You know, I had a patient who had problems sleeping and would wake up with nightmares because of his Parkinson's sleep REM, and his spouse next to him would be disturbed every night because of it. So you wonder, are we giving this clonazepam for her or for him? You know, but you know, we still talked about still getting them de-prescribed, but ultimately you wonder, you know, there is a fine balance because you want that quality of life for both, but our priority here is the patient.
Great. Here's a really good question about the prescribing cascade that came up. So in a prescribing cascade, would the length of someone being on a medication increase the likelihood of development of a side effect? What is the best way to communicate these concerns with the prescribing cascade with your physician? So can you repeat the first part of that question? Sorry, Joe. So yeah, really in a prescribing cascade, what would the length of someone being on a medication increase the likelihood of development of a side effect? Let's just focus on that. Okay, the length of someone being on it. I think a lot of times when so as you get older, you know,
body handles medications differently. So it might be that they were started on something. I have this conversation a lot with my patients. They might have been started on something when they were younger, and now what was once safe is no longer safe. So it could be that, you know, even though you didn't used to have these side effects, maybe you don't even know that they're there, that yes, that can develop as in the aging body. But you know, of course, when you start to medication or increase a dose, you know, or add in other medications, we of course have increased risk of side effects and drug interactions as well.
Yeah, I think she nailed it.
Wonderful. All right, thank you. Next question, and this came up, I think, across multiple questions. I think in part you addressed this in your slides, but I'm going to ask this anyway because it came up so many times. So are there any all natural products available to help prevent or promote strengthening the minds of dementia clients, even being before diagnosed? Can you give us the names of those products? Can you talk more about vitamins? What about fish oil? What about herbs? What do patients really need to tell? And really, what do we have some food that is associated to help people living with dementia instead of use of medication? So it's all kind of clustered in that same area.
Yeah, the best evidence right now comes around nutrition and exercise. So the Mediterranean diet, the Mediterranean DASH diet, where they focus on healthy fats, you know, beans, more veggies, fresh foods, they've been associated to have a reduction in risk of having dementia down the road. So I would probably be more likely to talk about that, getting people mobile, active, food as medicine. That's the approach I would use. We don't really have much of a verdict on natural supplements that will improve cognition or prevent any of that. But I do want to say it is important to make sure that all of their, you know, vitamins are basically balanced so that they're not suffering from any deficiencies. Like even having a thyroid deficiency can be associated with having cognitive impairment. So if your labs are good otherwise, frankly, there is no true benefit that we know of, at least to date.
And I think that, you know, as some other, he mentioned the thyroid, but, you know, vitamin D, B12, things like that. We want to make sure that they're not deficient in that as well. And those are not labs that are necessarily always checked. And so if there's concerns, you can ask your provider to check those levels.
Mm-hmm.
Okay, great. Some really great questions about de-prescribing here. And again, I'm gonna cluster two together. First, my wife is in Alzheimer's stage 5 or thereabouts. Is there a time when I should stop giving donepezil and memantine because it loses its effectiveness? And relatedly, my wife was diagnosed with Alzheimer's in 2013 following a complete battery of tests and brain imaging. She has been on donepezil for almost 10 years and memantine for more than 4. Do these medications still have value for her, and what would happen if she stopped taking the medication? So about 2 really great questions there.
Fantastic questions. It's hard to really tell what will happen, but that's why they have amazing tools like deprescribing.org, which can at least have you start a dialogue with your clinician on what's the real prolonged benefit of still using the donepezil or the memantine. So this could be something your prescriber can consider talking through with you. To your point, Amy, I'll let you add in what you like, but you know, I don't know if we can always tell what can happen based on the staging. Even the staging can be considered subjective. So I wouldn't want to just say, yes, you're stage 4, you got to do this. But Amy, what are your thoughts around that?
You know, I think if, you know, so we have donepezil and memantine on board, and pretty severe dementia, right? So I think, you know, looking at that, first of all, are there, I always look at potentially reducing or discontinuing these medications if there's been a change, again, in cognition or function, or if there's been potentially some side effects. So where I would typically start maybe in this scenario, and of course I don't know everything, you know, that's going on here, but this is something where I would consider, does it make sense to maybe begin a taper of the donepezil, since it's generally mild to moderate. I'm assuming this isn't a high dose 23 milligram donepezil. So you could consider, if they're on 10 milligrams, potentially going to 5 milligrams and waiting and see if there were any changes in cognition and or function as well. So, you know, again, talking to the provider about that and those concerns, I think is really important, because, you know, they do have limited effectiveness, and so things to watch for, again, as you taper, would be changes in that cognition or function, because, you know, sometimes you might see if all of a sudden you're noticing more confusion, or maybe it was helping with behaviors, and, you know, now you notice something, again, you want to monitor, and you could always go back up on it if you needed to. Sorry, it's kind of a long-winded response.
Okay.
She nailed it.
Wonderful. Another question asking for specific advice. I think this is so useful to use this time to do this. So getting to antipsychotics here, what is recommended for hallucinations and delusions that are keeping the loved one and the spouse up at night in Lewy body dementia? My father was prescribed Seroquel after an episode where he picked up a kitchen knife for quote unquote protection and would not put it down at a request for several hours. He has only done that once. Should we stop the Seroquel then? My mother thinks the 25 milligrams along with the 20 milligrams of melatonin helps him to sleep mostly through the night, with just a couple times to get up to use the bathroom. So again, really great kind of case here to discuss.
You know, I think I don't want to say you stop the Seroquel, because it might be, you know, it maybe is offering some benefit. Now, this again is there's safety concern here. Lewy body dementia, appropriate Seroquel would be you know, an appropriate option. So I think talking to the provider, you know, about, you know, if he's been stable for a long time, and you would, you know, or if wanting to look at potentially reducing, then talking to the provider about it, I think is important. And we do see melatonin used a lot too in Lewy body patients for the sleep-related disorders as well.
Yeah, again, I think it's all about timeline, and are they still a threat to themselves or others? And timeline, I mean the drugs. What's the timeline of the drug? How long are we going to keep it on board? If it's past that solution, or then it may be time to have that de-prescribing conversation for sure.
Great. I'm going to provide a couple really interesting comments that came up in the Q&A as well. And also, Michael Ellenbogen, be prepared, because I'm going to go to you next to ask a question live. So just be ready. I'm going to get to you here in a minute. So Kate Netarostic provided this in the Q&A. I thought really important comment. I published an article back in 2012 about how to reduce antipsychotic use in nursing homes, assisted living communities, since CMS called for a reduction in their use. It is unfortunate that communities rely on medication versus non-pharmacological methods. This is a very dangerous practice. And I think Kim McRae followed up with also a really important comment where she states, it is so important for all of us to realize that the misuse of these drugs are not just a nursing home issue. It happens in the community and everywhere, often starts while folks are in the hospital. So I thought those were really, really key points I wanted to emphasize to everybody here as we're going through our Q&A section. Okay, Michael, I am going to try to call on you. Is he still on? I think he left, unfortunately. I don't see him in my list. Oh, well, if Michael jumps back on again, I'm going to try to, oh, actually, Ashley, do you see Michael on here anywhere? I don't see him. Okay,
Give me.
well, yeah, maybe we'll go back to him. We have a lot of other questions to address here, so I'm going to loop back around to general questions. If the medical condition is controlled with medication, for example, blood pressure, does it still increase the risk of dementia, or is it simply uncontrolled disease? I thought that was a really great question.
Yeah, excellent question. It's mainly the uncontrolled disease that leads to it. Once it's managed, generally the risk factor can be reduced.
Going back to the prescribing cascade, what is the best way to communicate concerns with prescribing cascade with your physician?
I think that starts with, you know, every visit, again, making sure that you're going over asking to go over the medications, and if there's any, looking to see, is there, are there what are any bothersome symptoms or right now? I guess that would be the place to start, right? Is if there's anything that's happening. Are they having falls? What is the concern there? And then looking, to see if it would be appropriate, are all these medications needed? Could one be contributing to the other? It's just, it has to be a conversation at each visit. And I know I can't encourage people enough to I know a lot of times people are afraid to ask questions at their visits. They know their provider is busy, but please ask questions, and before you go, write them down. It's can be overwhelming when you're there and lots of things come up, but I think, writing down those concerns that you have before you go, and if that's about worried that the prescribing cascade is going on, a lot of times you're aware when something started, and then you kind of can piece together maybe, what happened when, and that, again, that timeline, you feel a bit like a detective, but bringing those things up if you have concerns that maybe a medication is contributing to something that you have going on.
Wonderful. Thank you both. Michael, I think we have you. Do you want to try to ask your question here?
Yes, thank you so much.
Sure.
You folks were wonderful. I cannot say, I could talk to you folks all day long,
Great.
but I'm going to limit it down to 2 comments. The first one is, if you can speak in reference to, and I'm probably going to butcher this, cholinesterase inhibitors. So many people think that you can only take them for 18 months, and that's only because the studies were only done that long, and they think that they wear off before that, and they should stop taking them. And I think that is wrong, but I will leave that up to you folks. But what bothers me more than anything else, and I don't know if you could even speak to this, is I take some of those drugs and I believe in stopping those drugs, but I have a fear, and so does many of my friends who live with dementia have a fear, that if we stop taking them, we can't go back and take the drug and recover to where we were at, because that seems to be what they say. Whether that's true or not, I don't know. But I'd love to stop my drugs. How do you deal with that?
Thank you, Michael. And as always, thanks for attending here today and asking these great questions. DeLon, Amy, please.
You want to go, or do you want me to, DeLon?
Yeah, we'll tag team it.
It's a great question, Michael. I think, well, first of all, I got to remember back to, as far as the amount of time that they're effective for, you're right, as far as, I think there's this misperception that they maybe are not, after 18 months, as you mentioned, that it's not going to work. And you're right, it's because that's what is studied. So that's where that comes into play. I think it's so individual, every patient is different. So, and I understand that concern and the worry for, if I cut back on something, am I gonna, have cognitive decline? Is my memory gonna get worse? Or whatever the case may be. And so I think, again, that if you're feeling that things are stable right now and you're able to do the things that you want to do, and and that in life, you're able to do life how you want right now, and I think that continuing is appropriate. I think that once maybe things are you're noting some decline, or maybe not able to, if you're losing some of those activities of daily living. Sorry, I thought I lost my screen there. Then that might be a time to consider reducing, if you're noticing some decline, or again, if you're concerned that maybe something is causing a side effect. But, I should stress too that doing one thing at a time is really important, so that we know what's what. So, so kind of back to the question about the donepezil and the memantine, I would, if you start with the donepezil, you do, again, one thing at a time, and then with regards to, worrying that you're not going to get your baseline back if you try stopping. That's why it is really important to monitor. And as the deprescribing.org mentions is, if after 4 weeks you haven't noticed a change, then you could consider reducing further. If you have noticed a change, then increase back to where you were. Sorry, DeLon, you have anything else to add?
Spot on, really. And it's going to be kind of your personal preference. And, we're in a space where we're trying to preserve cognition. I get it. But, using this guideline is a great way to have this convo, just kind of reassess. And again, we can always restart a medication if you feel like there are any changes in function or cognition after 4 weeks. So if it were me, I would still say to just stay on board and see how that does. But when things, digress or maybe worsen, that's when I would maybe start considering having that dialogue. Again, still a personal preference. You could still have this conversation, but to your point, we don't know about the efficacy. Truthfully, I've seen people with donepezil 5 for 20, 30 years and they're okay. And I've seen people, it worked for 3 months and now they need to be on everything and they end up having a severe decline. So it can really go any way. And like she mentioned, each person with dementia is, like you said, a unique person with dementia. Everyone is different.
Great. Another specific medication question here. Have sedatives been used to get patients to rest during recovery from COVID or pneumonia? For how long? Extra monitoring required to prevent falls once no longer sedated? Good question from Jan Marie Lundgren. Jan Marie, great to have you here today.
Did I hear sedatives for pneumonia?
Pneumonia and COVID. Yep. Let me repeat that.
Melatonin being used as a sedative for COVID. I don't think I've heard of it for pneumonia.
Are you saying to help with rest following a COVID diagnosis?
That, I believe, is what the question was. Yeah.
So I think, honestly, COVID actually brought up because it often causes quite a bit of fatigue, it's a great time to be looking at any medications that somebody is taking that's contributing to sedation, weakness, fatigue, because we would actually want to look at potentially decreasing or eliminating those medications if we could. So no, I don't think that would be appropriate to add on something like that for.
Yeah, I echo that sentiment as well.
Very good. So let's go to some deprescribing questions then. I thought this was a great question and probably indicates the need for more research in this area, but how often do you see an increase in cognition with deprescription? For example, 10% of people living with dementia, et cetera. Maybe even anecdotally or clinically, DeLon and Amy.
I've seen it anecdotally now, quite a bit, hear it often as well from caregivers. That is anecdotally, I can't say how long it's lasted. I definitely have had some who've graduated from hospice and are back living independently, or at least at home with a loved one. But I've generally hear more good with deprescribing than bad. Not to dismay that there are side effects associated with some deprescribing, but not all.
I think too, yeah, for example, so example would be somebody taking a benzodiazepine like Ativan or something like that for sleep or for anxiety, when there's and if it's potentially not appropriate, and I think that there's good information to show that people generally do better when they're off of them. People can be really scared to come off of those medications, but if we do it gradually and correctly, I think that we have really good success with it, and I've had a good success with that and seeing people's cognition improve, as well as mentioning like those dang Tylenol PMs and the Benadryl out there. That you see cognition improving and that fogginess kind of going away, confusion. So
okay. Again, a great question about antipsychotics here. What rights do families have if the MD in the memory care facility says the resident must have an antipsychotic?
I mean, I don't.
Yeah, it's a tough.
What was that?
I said that's a tough one. I mean,
Yeah. I think that's just really important to have those conversations about what you're, wanting for your loved one. And I mean, you're their advocate, and advocate for them the best that you can. And I think talking about what are potential other options, what are we doing from a non-pharmacological standpoint to help? I mean, I can't I know we talked a little bit about that, but there's studies to show too that scheduled use of Tylenol, for example, can help to reduce the use of antipsychotics because of patients having difficulty voicing that they're having pain. So just really trying to understand what the underlying issue is that might be contributing to that target behavior that they're wanting the antipsychotic for. So making sure, or what is talking to the facility about what is being done right now as far as non-pharmacological, and how can you work together to best take care of your loved one.
Okay.
I don't know if that's a very good answer, but
it's a tough question. I mean, it's very
Yes.
challenging. So, I think related to that, and we'll see after this, we'll have one final question, I think, or comment. Again, I thought this was a great one. What are the incentives for pharmacists to de-prescribe medications? Pharmacists are reimbursed by volume. So I'd love to hear what both of you think.
Sure. I think it's way past time that pharmacists are only recognized with a pill bottle or what you may see in a hospital. We don't bat an eye of having a consultant like a lawyer help you with a case. So I believe it's the prime opportunity for pharmacists to actually sell de-prescribing as a service to clinicians, to insurers, to health groups, to patients directly. That's what I do for my business. That's what I do for my patients. And frankly, it is so needed to just be educated generally around this. There's just ample opportunity. So I do believe that the tide is turning. I mean, I just came from our American Geriatrics Pharmacy Conference. It's like the first time ever they've had back-to-back lessons on de-prescribing. So I think the term is fairly new, but putting it into place is really percolating in people's heads now, and seeing that the cost savings associated with having a pharmacist before we're prescribing can really, really just change lives. And I think that's the future where healthcare is going. We want more personalized care. We want more integrative approaches to care using lifestyle medicine. And I think now is the time for pharmacists to really start leveraging our expertise and start selling and commanding the value we deserve to save patients' lives, which we do every day, and we love it. So I think the opportunity is now.
I think too, the incentive, I mean, just as far as the personal incentive, right? Like, this is why we do what we do. So when you de-prescribe and you're able to, I mean, probably almost every patient visit, I mean, you hear, I'm taking too many things. I don't want to take this many things. So when you're able to, successfully reduce the number of medications someone is taking and improve their quality of life, and, we see such gratefulness from people for that. And it's wonderful. So it's great incentive for me right there.
Wonderful, wonderful. So we're gonna close on this here. How do I find an Amy or DeLon to work with in my home county? In this case, San Diego County, but any county.
So, I mean, I would start with, probably the easiest thing to do would be to check with your clinic to see if they have any pharmacists that offer medication therapy management, or MTM. So that's where a pharmacist can sit down with you and go over all your medications, make sure that they're working for you the way they should be. So, checking with your clinic is a good idea to see if there's a pharmacist that offers that service.
Wonderful. And you can see Dr.
Yeah.
Canterbury is providing contact information in the chat. So it sounds like he's open to these kind of consultations. Please do reach out to him. Otherwise, everyone, I think we are ready to adjourn. What a fabulous panel today. I mean, gotten many, many positive comments. I just learned so much myself here today. Please do take a moment to complete feedback on our panel today. Ashley Millenbaugh has been providing those links in the chat, and I believe Ashley will follow up with an email as well. And again, remember, we will be providing you copies of the slides as well as a link to the recording of the presentation as well. So we certainly hope you'll revisit this information, apply it to your own situations or those individuals you work for or care for. Well, thanks again, everyone. I hope you are planning to have a wonderful holiday season and end of the year. Remember, we're always here to help. Want to thank the Minnesota North Star Geriatric Workforce Enhancement Program for providing the funding to support this event. If you have any questions, do reach out to us. And again, you'll be hearing from Ashley Millenbaugh shortly. Thank you, everyone. And also, you see Dr. Busker has provided her email address in the chat as well. Otherwise, thank you, everyone, and have a great rest of your day. Take care now.
Thank you.
Thanks, guys. Take care.